Hi, everyone. Thanks for joining. Let's just wait a few more minutes for everyone to join us. Okay, I think we can get started, and then we'll have people join us as they come in. So first of all, thank you so much for joining us for this webinar today. We are really happy to see that someone of you wants to come here about mental health in Malawi. So we are really happy to have Dr. Sandra Jumbe with us from Queen Mary, and also a special welcome to Chris Newby, who is a senior medical statistician at the University of Nottingham, and he has collaborated with Sandra on this study, and he will be chairing the event today. So my name is Gun, and I'm the communications manager at LIDC. So I will just welcome you and tell you about the chat box and the Q&A box. So if you have any questions, you can put them in the Q&A, and then we'll get to them after Sandra's presentation. She will be answering questions then towards the end of the event. And in the chat box, you can also put comments or general queries, these kinds of things. So without further ado, I think I will hand over to Chris. Thank you, Chris.
Thank you. So I'm Chris. I'm a statistician at the University of Nottingham with an interest in respiratory and mental health. I currently work on the NIHR-funded NEON Narrative Experience Online mental health trial within the recovery research team, but I also carry out statistical analysis on translated versions of English mental health questionnaires, and that's what I've been doing with Sandra with her work, so doing a lot of the factor analysis. So I also work for the RDS, the NIHR Research Design Service. So Sandra also works for the Research Design Service, and we've collaborated for quite a few years now. She is a health psychologist by trade, and she has an interest in health research and behaviour change solutions. She's also worked in process evaluations of complex intervention trials, but her current research interests include developing complex interventions for non-communicable diseases and understanding mental health in sub-Saharan Africa. So I'll leave her to start her presentation.
Thank you, Chris, for that introduction, and thank you everyone for joining today. Can everyone, is that looking fine, Chris? Yeah, great, okay, great. So yeah, thank you for joining today. My name is Sandra, and as Chris said, I do research with Queen Mary, as well as few collaborators in Malawi. So we have Millennium University, who are based in Blantyre, the National Youth Council of Malawi, and an NGO called Drug Fight Malawi, who implement community-based prevention programs for substance abuse and misuse. So today I'm just going to be sharing reflections, experience of one of the projects I've been working on, which is looking at improving mental health literacy amongst young people in Malawi. So to start with, just an agenda and overview, just going to give background about the research, why we're doing it. And then I'm going to be sharing findings from the qualitative study and survey that we have conducted in Malawi. And then I'm going to end with some reflections on what that means, particularly focusing on the use of language in the space of mental health from a Malawi context. Yeah, so just starting with a bit of background, why this topic, why this area. So research at the moment shows that depression and anxiety are very common mental health conditions that affect young people across the world, across the globe. So we will find that when we look at places which are low resource, particularly Africa at the moment, addressing this issue of depression in young people has become a healthcare policy need, it's become a priority. People are talking a lot about it. But when we look closely, more closely on the ground, we're finding that mental health literacy in Africa generally is still quite low. stigma within the society is still high, and the resources that are needed to be put in place to address the issue of depression and also other mental health needs still quite limited. And this is no different to Malawi, which is the southeastern region of Africa. So I've just pulled together some information from the World Health Organization Mental Health Atlas resource, just to give you an idea of how limited the resources are for mental health and also substance use disorders in the country. So when we think about Malawi, which has a population of just under 20 million people, the whole country, there are only 3 mental hospitals, or let's say units within a general hospital, and they're all based in the urban areas. So if you think of people who live in rural areas, they're particularly neglected. And when you think about things like outpatient facilities, there isn't much data around there. And it's just because of the working that I do and people I talk to a lot in the country. There is an organization called St. John that now started providing outpatient psychosocial services for people. And they're based again still in the city, so the capital city and in the north in Zuzu. But there isn't really, again, much data on that. In terms of treatment programs for young people, looks like officially there isn't anything there. And also looking at data, epidemiological data, to help us understand what is going on in the space of mental health and substance use, there is no data available. So you can see how sparse that is in that context. And then when we think about the mental health workforce, it's predominantly mental health nurses that are available in the country, but still there aren't a lot. There are 1.5, one nurse, let's say 1 or 2 nurses per 100,000 people in the country, which is really, really not much at all. And then when we think about psychiatrists, I know that for a long time, we've only had 3 or 4 psychiatrists in the whole country. And we tend to have also visiting psychiatrists that come across. There's a Scottish Malawi scheme where people come from the UK to go there and work with the College of Medicine or in the hospitals for a few months, and then they leave. Again, when we talk about psychologists, I think there's still only 3 in the country. I'm one of them, and I'm not there, I'm here. So the situation is really dire when we think about resources and help for people in Malawi. Thinking about mental health for young people in the country. So again, when you look at research evidence, it's very limited, but there are indications of high prevalence, particularly for depression, up to 20 to 30% so, amongst young people. There is also finding, research shows that when people in Malawi think about what causes mental health, a mental health disorder or problem, people tend to link it to issues around spiritual possession, witchcraft, substance abuse, so alcohol, drug use. And you can imagine having those links results in people feeling very stigmatized, being treated not so great, and also a lot of discrimination, not just for the person with the mental health condition, but also their family. And when you think about issues of substance use, again, there are extremes in Malawi. So there's quite a substantial proportion of, I would say, they're teetotalers, they don't drink at all. And then the people, the proportion that do drink seem to drink very heavily and have a very disordered relationship with drinking. So binge drinking, just addictions. And then more recently, we're finding, and I think this has also coincided with the coronavirus pandemic, but even before that, there's been an increase really in suicide cases in the country, unfortunately seeming to be affecting, again, the younger populations, especially young men in the rural areas. I think, though, when you look at some media, so newspaper outlets, online, printed, I think you get a better picture of what is happening in terms of mental health in the country, this issue of the presence of it and how it's affecting people. So you see things like this, substance abuse on the rise, the issue of people on the ground struggling to address drug abuse amongst young people, the cases of suicide going up, and that is affecting young people. And then more recently, we're finding that people are starting to link this a bit more with maybe there is something to do with mental health here that we're not addressing. And how can we address it? And people are starting to talk more, but it's still not enough. So this is what brought us to the project that I am leading in Malawi at the moment, which is looking to increase capacity for mental health literacy. And the hope is that if people are more knowledgeable about what mental health is, if people know how to identify it for themselves, but also how to identify symptoms or risk factors around their friends, family, and the community, they're more empowered to do something about it, empowered to help seek, empowered to try and manage those situations. So in our project, we're proposing to do this by targeting educational settings, particularly universities. So the aim was to develop a prevention program for universities, and we were going to do this by, first of all, going out and talking to young people to find out what are the issues that they face in day-to-day life that might cause mental health stress, and also what are their thoughts and views about just generally mental health. And then that would follow on with a survey. And the hope was that we would use the seed funding that we got from phase 1 and phase 2 to develop a culturally relevant prevention program that can be delivered in university settings. And this work would not at all have been possible without the stakeholders that I mentioned at the beginning, but also other people involved. So the university, my academic partner, Millennium, the Youth Council of Malawi, Drug Fight Malawi, and so on and so forth. So it's really been a long-term collaborative process of just talking and trying to tease out what's going on and what can we do about it. So I'm going to start by sharing findings and talking a bit more about the qualitative work. So when we got the funding, unfortunately, it coincided with the COVID pandemic. So I was meant to leave for Malawi in April 2020. So we were waiting for ethics approval and all the setup and all that stuff. And then obviously in March, the United Kingdom went into lockdown. At the same time, Malawi closed its borders. So they weren't allowing people in if you weren't a resident or you weren't Malawian. But also the schools closed. So that just affected where we were actually, the setting we were actually going to do this project in. We couldn't recruit, we couldn't really go into spaces because young people were told to go home. So I kind of pondered and thought, what do we do? How do I reach the young people I want to talk to for this project to start with? And so I thought social media. There are a lot of reasons why. I think a lot of people, quite a few people contacted me online about doing talks around mental health. And that I think just then organically gave me the idea to see if I can get people through social media. So I sent a tweet out telling people we've got this project. If you're interested, if you're a student in these universities, get in touch. And then Mary Rose from the Youth Council we've been working with did the same. So they posted on their website, their social media pages, and Millennium University did the same. And this proved to be a really effective way of recruiting because, so looking at the timeline, there just shows a timeline from that post to recruiting to doing the actual analysis of the study. So I posted in January, end of January, and within a week, I got 50 responses from the tweet that I sent. And then from the Youth Council, we got, and Drug Fight Now, we got about an additional 40 more responses. And in the end, we were able to conduct 10 focus groups over Zoom with a wide range of young people, so university students, graduates, youth leaders, and the focus groups were great. I learned a lot. People said a lot. I didn't have to really push for any. I would just throw in a question and people would just talk and debate and share. And it was a great experience. So we've analyzed that data and we've submitted it for publication. +1 is under review at the moment. So hopefully that will be published soon. But we also used a lot of what they said in those focus groups to help us to adapt the mental health literacy content that we were going to develop as part of the prevention program. So that was really fruitful work in the end. And also we were able to grow our stakeholder network. So we had a presence from the Young Feminists Network. It's a great group of young women. Some are still at university, some are graduates who do a lot of advocacy work around gender equality. We had presence from UNESCO and a few other organizations. So it's just, again, a thanks to those people for taking the time and having such an interest and passion in the space of mental health for their country. This is a summary of what people said. As I said at the beginning, they said a lot. So this is just a snapshot of the issues that were raised within the focus groups. So young people talked a lot about social, economic, and health challenges that they face as young people in Malawi. A lot to do about high like unemployment, limited or lacking opportunities, difficulty staying in school because of fees and that uncertainty. A lot around energy poverty. By that I mean high price of internet, utility bills, and that kind of impacting on their ability to have more access to online materials for learning, which was obviously a big thing during COVID, right? And then also this surge of pregnancies during the pandemic because young people had nothing to do. They were just told to stay at home. So there's a lot of loitering, I guess, that linked to unprotected sex. And then thinking about how are those people, especially young women, young girls, are they going to be able to go back into education? And what is the impact on their future as a result of that? These challenges fed into mental health, causing mental health distress, but also people talked about existing mental health and substance use problems. So depression, anxieties, there's a lot of social anxieties that were unrecognized by people's friends or family, particularly parents. The issue of suicide came up. So 1 or 2 focus groups, some students disclosed how they found someone on campus had taken their life and how they received no support at all, no counseling from the school, from the university as a result of that. And then also people talked a lot about COVID, what it meant for them, the fear that it brought, that their parents might not survive it, and that would remove their support structure. What would happen if they got it? And the impact on school and their education and life, and will life always be like this? So how do we recover from that, and how people lost their jobs because of it? So all these issues that people disclosed fed into increasing mental health distress, but then there was a recognition that there was really no support to help address those issues. A lot of that was to do with the limited access to services and also not having enough mental health practitioners, but also generally people felt that the low mental health literacy and stigma in the country meant that it was really hard to come forward when you were suffering, and you were just kind of seen as someone who was perhaps attention seeking. And again, that led a lot, people talked a lot about relationship issues with family, particularly parents, and that was a generational gap of, they felt like they knew a bit more about mental health, but when it came to the parents, they didn't have that a good enough understanding to take them seriously or to be able to support them in the way that they needed to be supported. And also there was a lot of pressure to look a certain way within the society, behave a certain way, have specific achievements around getting a good job after graduating, around marriage, around relationships and what that looks like. And overall as well, they just felt that the government or those in leadership were really detached from what the young people of Malawi need, and therefore they didn't really provide anything for young people to do on a lot of levels. I've just taken a snapshot from those many conversations, that summary, and focused on I thought I'd share some quotes that to me were very poignant and that were more focused around mental health communication, the challenge of talking about mental health in Malawi, and how do you go about describing how you feel, where do you go if you're feeling a certain way. So I'll just leave you for 30 seconds or a few seconds, just read those quotes and absorb them for yourselves. So yeah, reflecting back on what people said, I guess these were a few of the lessons that I came away with after that qualitative work. I think that it was very clear that there were limited spaces for young people to go to when they needed to seek help. There were no safe spaces as such to talk about mental health, although I think social media has become a great outlet for young people, particularly to at least talk about mental health. I'm seeing that more now. There's a lack of words to properly describe how you're feeling when it came in the context of mental health, in the local language particularly. And therefore, there was this push from people to say, don't just target us in educational settings. There's really a need for you to go a lot wider and think about how people feel, or talk about mental health in a broader community setting. So this feeds into the mental health literacy survey. So after the qualitative study, we went out and to do a survey across the country to get an idea of what is the base level of mental health knowledge across the country amongst young people, so typically between the ages of 16 and 30. And because of what people said about wider reach, we had a discussion, so myself, colleagues at Millennium University, National Youth Council and Drug Fight Malawi, and those two organizations, they were really, really passionate about, particularly about this thing, that we really need to, when we say rural, really need to go out into those rural communities and get those young people that are not typically the ones that would already be passionate or probably more knowledgeable about the space of mental health. Because I think because the focus groups were done online and Zoom, they probably attracted a particular type of young person, likely more affluent, more educated, they were studying in university or graduate. So we wanted really to get quite a broad perspective. So because of that, we decided to translate the survey questions into the local language to give people the option whether to complete it in English and Chichewa, basically. Because we had assumed most people in rural areas would complete in Chichewa, it's the local language. So we started off, I'm just going to talk through the process of translation. So I translated the original English survey into Chichewa because I speak both languages. And then I had two colleagues from Millennium University who back translated. So they took the Chichewa version that I translated and translated it back into English. And then we had a chat and a talk together discussing through things that were lost in translation through that process. Maybe terms that didn't really make that much sense when we linked it back to the original English. And then we did some pre-testing of the items. So with that, I shared the survey, the Chichewa survey, to about 7 people, to not just complete it, but also to comment on items that didn't quite make sense. And this was a very interesting process because people said, oh, I don't think this is quite the right term. But then when you ask them, what do you think is the right term? They also weren't sure. So again, I used the power of social media and I reached out to Facebook groups and WhatsApp groups that I'm in touch with, where we do a lot of mental health work together, and also just some community groups as well. And then we kind of adjusted the survey. And then we decided to administer it in 4 rural districts to start with, to see if how that went, how that would go. And then after that, we did some, Chris actually helped with doing some psychometric analyses where we were basically trying to look at, does it mirror the factors that came up from the original? So there were 4 factors, looking at knowledge, mental health, stereotypes, beliefs, help seeking, and then self-help strategies. So we were trying to see if vaguely we were answering those questions the same way. And it kind of looked like it was. There were a few interesting items that were a bit odd in response, but generally I think it was okay. So we rolled it out to the other districts. The next slide is just sharing the process of that pre-testing, back translation, sense-making of those items. So the terms that we really were struggling with, because people all had slightly different translations of them: mental health, depression, delusions. So this is a post I sent out on one of a women's group, Malawi group online on Facebook. And some people came back with some translations. So this person actually works as a mental health professional in Malawi. So she said, these are the things, the types of descriptions we use, and also what people tend to use, patients, clients, when they are in the clinic. So yeah. And then someone just also had a go themselves. But actually, Jen, I wanted to share more of these comments, where actually what people are saying is, it's just actually really hard to translate these words if they're out of context. And yeah, and then just some interest, people saying, actually this is really useful work, it's needed. But yeah, it's just difficult, I think, is what we learned from there. So this is an overview of the areas where we conducted the survey. So as you can see, we've kind of covered from north to south of the country, and also we've done a nice mix of urban areas as well as quite rural areas, lakeshore, that kind of thing. And there's just some pictures of, so this is Nelson and his team from Drug Fight Malawi, the people who went out, the field workers, to help with completion of the survey on the ground. And this is a group in Katabase, this is Happy, who helped us with collecting survey up in the north. And that's Mary Rose from Youth Council, and she did a lot of the surveying in the central and kind of lakeshore south areas. And this is in, I want to say Salima, and this is a predominantly Muslim part of the country, although majority of Malawi would say they're Christian religion-wise. Yeah, so and this is again in Zuzu, which is an urban setting. So yeah, we try to cover quite a broad spectrum. So this is a summary of our sample. So the average age, as we expected, was 21. We got a lot of people between the age of 16 and 25, which is great. In terms of education, as expected, a lot of people had completed primary and secondary school, but not many had progressed beyond that. And in terms of occupation, again, as expected, most of them were students, 45%. But there was high level of unemployment, actually, that noted, and I guess it's a parallel. It kind of fits with what people were saying in the qualitative study. And as expected, again, a lot of them were single. Just a snapshot of the people that we got, 700 odd. So again, I'm going to focus back on language, use of language, and how that translates to addressing mental health problems. So in the survey, one of the questions was, do you know anyone with a mental health problem? And just under half of the people who completed the survey said, yes, they do. And as a sub-question to that, we asked, what is your relationship with that person? So it's kind of interesting that more than half, definitely more than half of the people knew someone who was close to them. So either a relative or a friend who had a mental health problem. So this is a summary of, the next question is what type of mental health or what mental health problem does that person have? So this is a word cloud of the people who completed the questionnaire in English. So a common mental health problem was depression, but the biggest thing that people said was madness. And I've said this because there'll be, I'll explain this later when I share the Chichewa responses. But yeah, so depression, PTSD stress, brain disorders was an indication of something wrong with the brain. So those were more common responses. We also had things around substance use, so smoking, particularly cannabis, or heavy drinking. Then we have some unusual responses. The first one was leprosy. I was really confused. I thought, that's more of a skin disease. That's nothing to do with mental health. But then when, unfortunately, one of the responders translated it, gave the Chichewa translation for what they meant by leprosy. That's when I discovered that what they meant was epilepsy, not leprosy. So that shows a kind of a confusion of what exactly certain conditions are. So yeah, a lot about a few responses about epilepsy. And then people talked about others where they just, that person just seems very confused. I guess delusions, hallucinations, they don't think well, and some indication of suicidal thoughts there, some fears around that. Some people mentioned disability, which again is peculiar, so that linking disability to mental health for some people. And then another interesting thing was people talked about violence, antisocial behavior, so being angry as a mental health problem. So those are the English respondents. Now this is what the Chichewa responders said. And sorry, I've put it in Chichewa because it's just a way of helping me remember what people actually said. So this will be a bit of a lesson of Chichewa in an English translation, I guess. So misala was a big thing, and misala is translated is madness. So actually that word misala is a really common term. If you ask most people in Malawi what is a mental health problem, they will say to you misala. But actually the translation for misala is actually mad, colloquially, but also in terms of formal mental health care. If you say someone has misala, akudwala has an illness of misala, it's actually psychosis. So I've put a list of other translations there just to help you. So again, depression was a big thing, or this issue of the brain not really working well, like having issues understanding things, anxieties came up again, epilepsy. A lot of people mentioned memory problems, which didn't come up with the English responders, and also again, substance use, which was again a trend. So there are a lot of overlaps with madness, this concept of being mad as a common thing. But then they also, so this was about 50% of the Chichewa responders. But the other 50% came back with words like this. And again, it's in Chichewa, but it's just to trigger me to explain. So the biggest thing that people describe as a mental health problem is kumenya. So kumenya is like someone who's violent, so hitting or fighting with people randomly, stealing. Yeah, so these aren't mental health problems. These are antisocial behaviors, it's criminal activity, but being angry. But they are linking that and saying this is the mental health problem. And we see that societal stigma and why people might hesitate from coming forward to say, I think I'm struggling mentally, because they don't want to be linked to someone who is violent and hitting people and stealing and conducting criminal and social behavior. So that linking of mental health with violence is something that needs to be addressed. There are other things that they said, like wandering around aimlessly. So that's the top one there. Being too talkative or not making sense when they talk. Again, could be indicative of someone maybe suffering very much, maybe going through psychosis, delusions. So those are, I guess, actions, behaviors that could indicate a mental health problem, but they don't actually know what the mental health problem is. And other things like migraines. So those are very interesting in that with the Chichewa responders, some were able to pick or identify an actual mental health problem like depression, anxiety, but quite a lot of them were just talking about ways of behaving, acting, that they think are a mental health problem. Then we have some more obscure responses. So one person said, the person that I know who has a mental health problem suffers from malaria. That's the translation. Malaria, mental health. I kind of thought, were they trying to talk about the fever or the hallucinations that you get when you suffer when your malaria is quite, when you get quite badly stricken by malaria, and that is what they were linking to mental health problem. Other people talked about poverty-related issues. So they lack fees, I assume school fees, or they go around begging, and others talked about relationship problems. But in themselves, again, these things are not a mental health problem. So I found it really interesting how people were linking these things to actually being a mental health problem. So I will stop there and just conclude. So what reflections and lessons, I think a lot, but I think I've summarized it to these 4 things. I think firstly is that what I've learned from this project is that beyond lacking service provision and the existing stigma in the society in Malawi, communication adds another layer of, or another challenge to actually providing effective mental health support for people, particularly young people. And that the common mental health terms that we use in the space clinically are typically very Western concepts. So actually, I think we need to think about how do we develop a local way of talking or describing or defining these terms in the different settings that we're working, so that it's clearer what we mean, and also to avoid things being lost in translation. For example, the translation for kumura is to feel low, but how do we differentiate whether that low mood is clinical depression versus just feeling low? And then lastly, I think there are definitely, what I'm finding now is the cultural nuances, indications of health and well-being that still impact on understanding of mental health. And what I'm trying to say about that is this. I'll give Misala as the typical example. Again, it's a nuance. It's, as I said, the translation for Misala is madness. But is it, when people say you're mad, people can use it in general terms, just jokingly, and say you're mad or whatever. But actually, when it comes to clinical sense, people don't want to be associated with that word because of the stigma that comes around it. So if people say that person's mad, the images that will typically come in the head of a Malawian, especially me growing up in Malawi, is a person who is walking around the street aimlessly, no self-care, neglected. They don't care for themselves. They can be violent. They can hurt you. There's a fear. There's a almost dehumanizing of the person. So if we use that word, what impact does it have on people? Will people want to be associated with that word? And then what is the impact on people then trying to seek help for that? And then also, I think it's this thinking of extremes, in that you are either okay or you are either mad. I think people don't really understand that mental health is on a continuum in the same way as physical health. Like today, I could have a cough. Next week, I might be absent of that cough and be in good physical health. Whereas, when you have a cough, you're poor physical health. In the same way, I think people need to understand more that with mental health, one day you can be suffering mentally and be distressed or have low mood, and the other day you can be feeling great. That is not a one or other, it's only a continuum. But I'll stop there and I'll just leave you with that quote there, and that's from the paper from talking about suicide in Malawi. I just thought that quote was it just explains it all. I think as a country, we need to prioritize mental health, the issues that exist, understanding the concept, because without that, there is no help. So thank you for listening. Sorry, I went on a bit. And yes, more thank you to all the people who actually completed the survey and took part in the qualitative study. Yeah.
Thank you, Sandra. That was really good. Really enjoyed it. And so I think we have some questions now.
Yes, so I see there is one question in the Q&A box. And also, if you have a question you'd like to ask yourself, you can also raise your hand and we'll unmute you.
Okay, so we have a question in the question and answer box, and it's an anonymous attendee, and they're asking, did you find that the demographics of youths recruited through social media were different to who you would normally get in touch in pre-pandemic times? And if so, in which way?
Yeah, great question. I want to say definite. I think yes is the answer to that. I kind of said a bit about this before, and I think also how that influenced the change in recruitment strategy for the survey. I do think that we got a particular group that are already passionate about mental health and mental health issues, or quite a few of them actually work in the space. So they're social workers, for example, or mental health nurses. So yeah, definitely we got a different type in that way. I don't think they were different post-pandemic. No, I don't think so. But I think in terms of their interests, we probably got a group of people who were already consciously or unconsciously advocating or advocators of mental health in a way.
Okay, we have another question from Esther, and she says, how did the views about mental health differ between the participants recruited via social media as opposed to the digitally excluded group?
Yeah, I guess we didn't really get a chance to. I think everyone we did the focus groups with was from social media, I guess. We had one or two who came through Drug Fight Malawi, and I think those tended to be practitioners, so young people working in that space. So maybe that was the difference. Their views, I don't think their views within the focus group, definitely. I think people had similar views all across the board. I think one contentious issue was maybe gender differences. There were a few gender-related issues, but yeah, aside from that, I think, yeah.
Okay. We have another anonymous question. What do you think is the cause behind the stigma surrounding mental health issues in Malawi?
I don't want to say, well, so this is my view, it's not an expert view, I'll make that disclaimer. So from my experience, I think it is that thing that you are either, when you have a mental health problem, that's it, that's you, that there's this perception that perhaps is not cured, or also that your family could be cursed because of that linking to witchcraft or potential spirit possession, or that you've been cursed and that kind of thing. So it then becomes a thing about your family. So people would rather just care for the person at home and try and hide it until the person has been treated and it's gone. So I think though that's the main cause behind the stigma, the myths around what causes mental health, but also this thinking that that's it, there's no cure for it. You're a mad person, and therefore you can't be a functioning citizen, basically. So it's those two issues.
Okay, so I have a question from Hannah, and she says, "Thank you for your presentation. Were there any challenges with discussing mental health in Malawi while navigating religious beliefs?"
So I think actually this was an interesting topic and a point of debate. So some people believe that faith-led organizations could be a good way to get people to talk more about mental health, and then also as a point for seeking support. So that was one argument or thinking. And then the other thought was actually the opposite, where some young people, I think it's just particularly university students, felt that religion should be kept out of therapy because sometimes, and one person shared a personal experience that if you put everything to like religion, like pray about it and God will help you, and you pray about it and it doesn't work, you're still depressed, you feel like God doesn't love you. And so it can actually drive you away from your religion or your religious beliefs or your faith. So they felt that actually should be professional. That was one of the barriers they felt for accessing the counseling service where they were, because they said it was very faith-led, and the counselors were quick to say, here's a Bible verse, meditate on this and you'll feel better, and so there were those two thoughts that came up in terms of religious beliefs.
Great. I've got a question from Victoria, and she asks, would it be useful to ask about experience of specific symptoms such as fatigue and low mood? And even though mental health is understood differently, does it still have the same effects?
Yeah, so that's a really good question.
Yeah, it's a good one.
Yeah, I kind of agree with that. That might be a different approach to teasing out more. Yeah, thank you for that, Victoria.
And one from Ivana, and she says, what lessons from your research can we bring to mental health considerations in the UK?
Quite a few, actually. So, so in my with the research design service, I'm also, well, both Chris and I actually, we are also part of the equality, diversity, and inclusion working now. And this has been making me think a lot about how people from minority groups access mental health services here, particularly people who are not, maybe English is not their first language. And I think I think there are a lot of things that can translate to here, whether being more conscious about whether the terms we use as professionals, or the training we receive here, whether that translates to every patient we see. Or maybe we need to be more conscious about who someone is and culturally and ethnically where they're coming from and what those terms mean to them. And also the issue of stigma, because just because you live here, you've moved here, it doesn't leave behind those notions or those stigmatizing or stereotypical beliefs that exist in your community. So I think in the same way, I think that the issue we found in Malawi is kind of relevant here. I don't know if that answers the question.
I think it does. I think what's striking about your research is that you've concentrated on some of the rural areas, which are difficult, well, more difficult to reach because of infrastructure kind of things, and a lot of the research in the UK is around universities and hospitals, which are usually urban, aren't they? So I think that's really good. We have another question. What do you think is the best way to start creating a local mental health lexicon? Do you think it should be health workers or community driven?
I think we need both. I think we need interaction between both parties so that we kind of meet in the middle. I think that would be, I don't know what you think, Chris.
I think, yeah, it's a communication, isn't it? I think both are needed, definitely. But I think sometimes there might be kind of words from the community that don't really have a good translation back in English. I didn't know whether there were any, but you found that were like that. Did you find any mental health words that were difficult to translate back into English?
I think, yeah, even depression, I think still is quite, is it low mood? Is it very low mood? Is it, some people prefer to say, you know, someone stuck in darkness. That was the literal translation, because it's not just low mood. Yeah, but I think there are other things that are not just mental health. So the word behavior, I don't know if Mary Rose and Joel are online still, but yeah, so that how to translate behavior in the way that we conceptualize it in English, in psychology, actually, that was very difficult. Like an action, or is it a way of being versus a thought process? Yeah, they were complex. Yeah, just a word you think is straightforward, but actually translating it, it has to be put into the context. Yeah.
And what comparison in literacy was there between those in rural areas and those in urban areas?
We haven't looked at that yet. I don't, yeah, I feel like I can't comment on this thing because we haven't, it's still preliminary analyses, isn't it, Chris?
Okay, and we'll move on to someone saying this is a fascinating discussion, and what do you think the next step should be for mental health in Malawi?
There's just so much scope for a lot to be done, but I'll share what we're thinking of, what we're planning to do next. So we've already started a bit of intercultural work. So what we're trying to do is use cross-cultural intercultural. We're trying to use creative approaches to research. So we've got a group of students from Queen Mary University working with students at Millennium University. So they're studying social work, public health, graphic design. And the aim is to kind of create a space where they share their experiences of mental health. They either like review an article on mental health and talk about what they think about it from the different perspectives culturally, whatever. And then the overall aim is for them to create artwork, animations, photos, but also resources that can then be shared to other young people talk about people's experiences of mental health, how we portray it in different contexts, different settings, as a way to just get young people to talk more about it and to share. Another thing is we're trying to build a website of resources, not just talking about knowledge, stuff, or breaking stereotypes, but also signposting young people in Malawi to free, vetted, youth-friendly support. So that's why it's really important, the networking, the public engagement parts, building a network of people working this space so that they can be people can be signposted to them, so that they can access free support. But there's so much.
Yeah.
That could be done.
That might link in with the next question of from Esther, and it says a great project which clearly shows a need, and then she's wondering if you have a picture of what the intervention would look like based on your findings. And she says it's still early days, so it's okay if you do.
At the moment, the intervention that we're hoping to pilot in the feasibility type studies. So we've created an e-curriculum, an e-mental health literacy type curriculum, which can be accessed online. So the hope is that we're going to try and deliver it in universities in Malawi so that all first-year students, when they come in as part of their first year, they go through that module. Hopefully it'll be like a 1-2 week type thing. And we will assess impact on like mental well-being, performance, being exposed to that, but also just get feedback from them about how they felt going through that module, whether it was useful to them or not. So that's what we're trying to do. My hope is that actually normalizing mental health in the curriculum would hopefully again be a way of getting people to think more about it, if not more, like talk more about it, and then it's more conscious on the mind. So that's the plan. That's what the intervention is.
Great. We've got a question from Catherine. Do you think the same intensity of stigma is applied to Wamisala as to someone with their antisocial or eccentric behaviours described, talking too much, etc.? Or are these accepted within a more holistic view of people's mental health and behaviour?
Not sure I get the question. What do you think?
I think the question is around, is this a stigma applied to the word Wamisala as to someone with antisocial eccentric behaviours, kind of.
Okay, so the degrees to which they are stigmatized. I think the term.
She also goes on to say about, sorry, go on. What would say?
I don't know, you know. I think I do agree with there are some behaviors more acceptable in men rather than women. So the thing of drinking heavily and smoking is kind of sometimes in some tribes, in some cultures, some settings is seen as a rite of passage for a young man. People said that in the focus groups, but I still think now, if you're a young woman or if you're a woman and you smoke, it's just really is a taboo. It's like, why would you smoke? And this is not even illicit drug, it's tobacco smoking. It's like, why would you smoke as a woman? And I think to an extent drinking as well. So maybe those behaviors. The Wamisala thing, I think in terms of intensity of stigma, yes, I think it's more negatively viewed as opposed to someone saying, oh, you fight, especially let's say if a man has those antisocial behaviors, they're just very angry or they fight, they lash out a lot. I think that's again more acceptable. It's kind of it's just weird if people know you as an angry woman, right? Women are in Malawi, I don't know if it's changing, but from my experience, there's a desirable, you have to be quite meek and just tame and soft, and even your tone and how you speak, you kind of reduce your volume and you're gentle, that kind of thing. So yeah, there are those nuances, but I'm not sure how they would fit into mental health per se, but I think behavior-wise, maybe those things do feed into how people view people's mental health. Actually, I'll be interested to know what Catherine thinks. It's a really interesting question, and what her thoughts are. I don't know.
So sorry to interrupt there.
Oh, sorry.
I think we've run out of time. We've had so many great questions after really a fabulous presentation. From LIDC's side, I'd like to thank Dr. Dr Jumbe for coming today, and also Dr. Christopher Newby for hosting the event today. I don't know if there are any last sort of reflections you'd like to share with the audience today.
No, not really. I actually wanted to bring in Mary Rose at some point to talk about the service, but I don't know if she wants to. I don't want to put her on the spot. But from myself, I feel like I've talked a lot. So maybe I should just not say anymore and just thank everyone for your amazing questions and also just being so interested in this topic.
On my side, it was really interesting, and a few people have said around sharing the slides and the recording. Is that possible?
Yes, so the recording I will post on the website. I'll send an email to everyone who signed up for the webinar once it's online. If Sandra wants to share her presentation, I'd be happy to also upload that on our website, or put it in the email, or whatever you prefer. So I think, yeah, just finally for me, we have another event in 1 week at the Action Against Stunting Hub. If you're interested, please do join us. You can find more information about this on our Twitter feed. And apart from that, thank you so much for joining us today, all the whole audience, and also, of course, Sandra and Chris. It's been super interesting to hear about the research and to learn more about mental health in Malawi. So thank you for that.
Thank you for having us.
Okay, all right. Have a nice weekend when that time comes.